Good afternoon, everybody. We'll get started. Welcome to the first Food for Thought for 2026. May I acknowledge the traditional owners of the land on which we meet today, the Whadjuk Noongar people, and pay my respects to elders past, present and emerging, and I extend that respect to all Aboriginal and Torres Strait Islander peoples. Before we start today, I want to share that an announcement about the 2026 Career Advancement Fellowships grant program will be coming out in the first half of this year. We're just working to finalise the program. And we do encourage all of you to sign up for our Signet mailing list so that you can stay up to date with our programs. And if you're not already signed up, the QR code is at the back of the room, and please feel free to scan it and or email our team, and they'll have you added to our list. You'll, of course, all of those people who are present today will be aware of the capital works underway. It won't be long now before we have 2 new lifts in this building, and I hope you're all enjoying the improved amenity that the new concierge service, refurbished courtyard and cafe have brought us. Now it is my pleasure to introduce our first speaker of the year, Associate Professor Judith Katzenellenbogen. Associate Professor Judith Katzenellenbogen's expertise in epidemiology has underpinned a public health career in South Africa, New Zealand and Australia. Currently, she is lead Aboriginal cardiovascular disease at UWA's Cardiovascular Epidemiology Research Centre at the University of Western Australia, heading a multidisciplinary team of quantitative and qualitative researchers and collaborating widely, nationally and internationally. Her research applies innovative linked data methods to coronary heart disease, atrial fibrillation, heart failure and rheumatic heart disease research, including in the Aboriginal health context. Her program applies linked data and mixed methods to studying Aboriginal chronic disease, building capacity, and advocating for change to improve Aboriginal health. She leads projects that utilise data from practice software in Aboriginal medical services, initially for Strep A, and is now extended to other conditions. Through her involvement with Murdoch University, she has been centrally involved in a national disaster risk reduction funded project with the Whakathuni community in the Pilbara related to the impacts of heat on health. Today, she will be presenting on contemporary issues and initiatives in Aboriginal cardiovascular health in Western Australia. Please join me in making her welcome.
Thank you. Thank you very much. And I'd also like to acknowledge the Whadjuk Noongar people as the traditional owners of the land where we meet today. This is a model of pre-colonial Perth, which is a lovely image. So I work with a group of researchers. We do mixed methods research to support cardiovascular health and well-being among Indigenous Australians. This is our kind of core team. We also work with various others from other organisations and states, and also some cardiologists. So there's 2 RPH cardiologists I'm just mentioning here, James Marangu, some of you might know, and Steele Butcher. They're doing some projects with us as well. So I'll do this talking a bit about, I'm kind of rushing through my talk because I've got 3 topics. The one is just RHD, a quick whistle through that. We've got some analysis on acute coronary syndrome and stroke, as well as the Whakathuni project that I'll talk about a bit, about the effects of heat and so on. Before I start, I always acknowledge that the statistics presented here represent the loss of health and human life with profound sadness and for people, families, community and culture, and that this can't obscure the resilience and strengths of these people. I feel I always have to say that. So in Australia, rheumatic heart disease shows evidence of 2 concurrent patterns. We've got the non-Indigenous pattern, which shows the previous epidemic before the 1960s. And among Indigenous people, there's an ongoing epidemic where mortality rates are 18 times that of non-Indigenous under 65, and about 12,000 people on the registers, predominantly Aboriginal. This shows the same message, really, that it just shows the age breakdown of Aboriginal and non-Aboriginal people for ARF in acute rheumatic fever in red, and in blue, rheumatic heart disease. And you can see a very young population and very active acute rheumatic fever among the Indigenous, whereas for the non-Indigenous, mainly older people, reflecting the previous epidemic. So we focus our work on under 55s and under 65s, the more current epidemic. We all know, and I'll just quickly go through this, is that strep A starts with either a skin or throat infection that is, if untreated, might develop into an autoimmune reaction called acute rheumatic fever, and on repeated episodes or severe ARF, people get chronic damage to the valves, the heart valves, and in some cases it's so severe that it causes substantial reduction in life expectancy and quality of life. But more importantly than the medical stuff is really what sits under it. And what it is that we have, the effects of colonization have been that many Aboriginal communities and people find themselves in a position where their social environmental and economic situation is compromised. And this is really things like poor housing, poor access to healthcare, all those things. I can't see very well there what's on my slide, but and so it is really sort of, there's a whole cascade that happens because of those life conditions, and that's really underpinning what's happening in Aboriginal rheumatic heart disease. And so if we want to intervene in those, we have to intervene at every level. And all of you are, I think, very involved with maybe the top 2 levels, but we need to be working at every level, particularly at that one, at the brown level, which is the social determinants, where that's really where the big difference is going to happen, is at that social determinants of health level. So there have been various RHD programs introduced progressively in Australia. In 1997, we had the first rheumatic heart disease register established. There's now 6 registers in 6 states, and with that, notifications as well. And the government introduced the rheumatic fever strategy in 2009, focusing on registers and secondary prevention. And the RHD Endgame was published in 2020 by a coalition of researchers, Aboriginal sector people, NGOs, including the Heart Foundation, aiming to remove RHD as a public health problem in Australia by 2030. Well, time has come, so maybe we have to move that goalpost, but that's still what it's about. And there was a much greater focus on primary prevention and Indigenous leadership in that strategy. So our ERASE project, which is an epidemiology one, was part of that RHD initiative, and the idea was to give good epidemiological information to underpin some of the policies. And so we linked hospital death and register data. We had phase 1 where we looked at the burden of disease, and phase 2 where we focused more on outcomes. And it relates mainly to 2001 to 2018. We now need an update of that, but that's another story. So here we see just an age-specific rates of acute rheumatic fever among Indigenous people here in those 5 jurisdictions. You can see in the light, the orange, the sort of the very great increase at between 5 and 14, which is the age group which is most affected by acute rheumatic fever, and then reducing with age, whereas RHD prevalence, which is in red, goes up with age, and a huge increase after the age of 15. And severe RHD, which is the dotted one, a gradual one, increasing with age. For non-Indigenous, it's tiny, the acute rheumatic fever, you can't even compare, the axes there. And for RHD prevalence, just a gradual increase with age. And I think the people getting into our database are mainly the severe ones, because there's not many milds if you can see the graph there. More importantly, maybe for us to know, is the difference between the males and females. And we can see here that both males and females sort of have similar rates at about 4 to 15, but after that, the female rate really doesn't go down as quickly as the male. So there's a greater risk. And for rheumatic heart disease prevalence, the female rate is the one that's sort of billowing up after the age of 15, presumably because they're being picked up also through the reproductive pregnancies as well as being around kids. And so a lot of the mild cases are also getting noticed, whereas for men, it plateaus, and we think that we're probably missing some of the milder ones that haven't been diagnosed in this graph. And then just a slow gradual for males and females going up with age for the severe side. This is just a heat map of Australia showing the north-south gradient in rheumatic heart disease. This is acute rheumatic fever incidence, with Northern Territory and sort of Eastern Pilbara, Eastern Kimberley being really the highest rates. And for rheumatic heart disease prevalence, again, that north-south gradient and the top end just being, dominating or having very, very high rates. Prevalence, not rates, sorry. And this is just the same information for Western Australia. It's actually just the same graph, just highlighted there. So the differentials are probably as high as you're ever going to get. The Aboriginal acute rheumatic fever rates are 120 times that of non-Indigenous. Northern Australia, and particularly Northern Territory, just having very much the highest rates, sort of reflecting what we saw in the maps. And the age standardized prevalence was 61 times higher in Aboriginal compared to non-Aboriginal people under 55, and females twice as likely as men. So that gives the idea. Now, Ingrid Stacey, who was a PhD student of mine, is now a postdoc. For her PhD, she looked at some outcomes. This one is a study where she looked at young people under 35 who had uncomplicated RHD and looked at their outcomes. And we see, she followed them for up to 8 years and found that a composite of all complications that you see highlighted there, about a quarter of those people had those within that time period. And what put people at risk for these complications was, first of all, later age of diagnosis. So the later you're diagnosed with RHD, the worse, the more complications you get, because there hasn't been opportunity for prevention. And also metropolitan location, living in Perth, which is an interesting one. So we can talk about that later. And a prior record of acute rheumatic fever diagnosis is protective, because probably you were then treated and you got secondary prevention. And so if you do have RHD, it's milder. Ingrid also did a study looking at outcomes for mothers and babies. I'm just focusing on the mother one here, where among women with uncomplicated RHD, about 5% experience a cardiovascular complication during the pregnancy. And she also found, through another analysis, that they were 12 times more likely to get a complication in pregnancy compared with not pregnancy states. So pregnancy stresses the heart a lot, as you know. And among women with complicated RHD, about 40% had an additional complication develop, and they were 6 times more likely to have an additional complication compared with non-pregnant states. And so this really is showing the need for culturally safe cardio-obstetric care for women with RHD. So just coming back to my pyramid, just to say that there's a lot of research going on in Australia, but quite a lot in WA as well, and there's quite a small research community, so we all collaborate. Lots being done at various levels of prevention, but lots in the primary prevention space. We also got some innovative stuff with the secondary prevention as well. So I won't go on into detail with that, but to say that I don't know if you all know about the Furry Spotlight program. It's now funding disease specific for 5 years, and RHD is the first disease, and I think it's next week that the applications are in for the leadership of the 5-year program. So that's RHD. The next thing I'd like to talk about is something I've been planning for about 10 years through my fellowships, and we only just got around to doing it now, which was to look at trends in the incidence of acute coronary syndrome and stroke among the two populations, and looking at that in relation to closing the gap. 2 separate teams have been working on that, so I've sort of color-coded them. When I show my results, you'll know which one I'm talking about. And the one on the left, the acute coronary syndrome, actually the paper came out this week, so yay for that. So as you all know, ACS, along with all cardiovascular disease, contributes substantially to the 8-year life expectancy gap between Aboriginal and non-Aboriginal Australians. And closing the gap was there established as a policy framework and funding to address these inequalities, and monitoring of changing these the changing disease patterns is important to determine if there's been an impact of closing the gap. So our aims were to investigate these temporal trends between these two diseases among Aboriginal and non-Aboriginal people in WA between 2003 and 2020. We described the trends in the incidence, and then we compared trends and differentials in relation to Closing the Gap initiative. So this was a population surveillance study where we used linked data. We identified people from ICD codes in the administrative hospital data and death data. And we also used, for our denominators, we used ABS information about the population numbers. And they provided us with two series. There's a series for 2000 to 2016. And then a second one overlapping, 2011 to 2020. And the second series, the numbers are larger. So we have an overlapping time when you can look what's happening to the rates, and the larger your denominator, the lower your rate. So it's quite difficult to look at trends across the whole lot because you've got a different series. It's sort of a systematic error. So we had to be very careful that we could only look at trends within certain periods where the denominator series was the same. And we had a lot of effort in terms of Indigenous identification. So we analysed, stratified by Aboriginal status, sex and broad age group. We had a younger age group, 20 to 54, and an older one, 55 to 84. And then we directly standardised these, and we also looked at incident rate ratios, and we also looked at the annual percentage change within particular periods. So we didn't do one period, we did chunks. So for ACS and stroke, the pre-closing the gap period was 2003 to 2008. ACS had an early and a post-closing the gap period, whereas stroke just had one because of the small numbers. And you can see that last series we used that second series for that estimate. So our profile of the patient shows, as I think we all know, that in both diseases, females are a higher percentage of the Aboriginal cases than the non-Aboriginal cases, and that young people are much more, a bigger a proportion of the group than older people compared with the non-Aboriginal, and that rural residence was much more frequent among Aboriginal patients. So that's just a bit about the profile. This shows the age standardized trends over time. In blue, the solid blue is Aboriginal population series 1 denominators, and the dotted lines is population series 2, and you can see the overlapping periods that there's a difference in rates, particularly obvious in the young men, so I'm not sure why that should be, but it's showing up there. And we can't really make out if things are going up or down. It looks like men may be down, young men, and older men and women also seem like they're going down, so we'll look at the trends in more detail here. So this is the looking at the annual percentage change. We can see, let's go for non-Aboriginal first. Before closing the gap, there was already a reducing trend among older men and women. Early post-closing the gap, all non-Aboriginal strata were reducing, and further reduced in the later period. And the other one, the younger women, it wasn't significant, but it's going down as well. For Aboriginal, the only significant trends were a 5% reduction per year post-closing the gap in the early period for older men and younger women. So we don't see as much movement in those rates going down. Looking at the incident rate ratios, we can see, is the relative gap reducing? And so we're comparing the rate ratios in the different periods to the rate ratio before closing the gap. And the only significant change has been a reduction in that closing of that gap for older men that you see highlighted there, from 2.9 to 2.1. Now looking at stroke, this is the same age standardized rates. Nothing much happening for young males and females, Aboriginal or non-Aboriginal, and we'll come to that a little bit later. For older men and women, quite a lot happening before closing the gap. There was something happened in the management, I think, of stroke risk factors that has somehow had a big impact all over, particularly for the men there. So let's have a look at what the trends are telling us. So before closing the gap, for young people, nothing really significant, except maybe even an increase for young females after closing the gap, post-close. So stroke, young people are in trouble for stroke. That's really whoever you are, Aboriginal or not. For older people, we see that the males had a really substantial sort of 9% per year reduction in that early period. And for Aboriginal and non-Aboriginal was going down as well. And that post-closing, and for females, the only females that continued going down all the way were the older non-Aboriginal females. But yeah, so nothing significant for Aboriginal females, older females, but it was going in the right direction before closing the gap. So let's see what the rate ratios say. And the rate, because things are going up and down for everybody, what is the relative risk there? And so we see that there was significant reduction in post-closing the gap rate ratios for young men, older males and females for Aboriginal. So there's been quite a lot of progress for that for stroke. So in summary, there was evidence of a reduction in rates for all age groups for non-Aboriginal people. This is the first one, except for young females. The early post-closing the gap period, there was a significant Aboriginal reduction among older men and young women, but this improvement wasn't sustained in the later period, and the gap has not widened. That's good. The reduction in gap among men in the latest period was significant, but only significant for the older men. For stroke, there was a substantial gain before closing the gap. So that had nothing to do with closing the gap. It's got to do with other things. There was no significant changes for younger people, and gap has not widened and is likely reduced for some strata for Aboriginal people. So stroke, better news than ACS. And I think we really are talking about we need long-term intergenerational commitment here. Incidence is not something that has got to do with how good your medical care is. There's many more issues that go into incidence. So moving on to the Whakathuni Heatwaves project, there was a extreme heat. I've decided only to speak on the scope on the one on the left because of time. Georgia Chasing, who's a Sydney-based researcher, had put out a scientific statement representing a whole bunch of professional organisations around heat extremes and cardiovascular disease. And really, they summarise the epidemiological evidence for heat-related cardiovascular disease. They also focus on the physiological responses, the cardiovascular ones, and what heat does in quite a lot of detail, and talk about the impact of social inequalities, how people who don't have access to heat, money, good housing, and those kind of things are really compromised. So there's really a need to focus on those. Also, there's an important paper that's been out by general practitioners about an evidence-based approach to preventing heat-related illness, highlighting the essential practice points for GPs, and also discusses the expanding evidence on direct and indirect heat-related health impacts. So this is just an example. I just took some of this table. It's a table about the life course, and it just says what they recommend GPs do for people in these different life stages. And importantly, there's actually a fantastic table talking about the heat sensitizing mechanisms of common medications. And because that's obviously a big issue, is the side effects of medication and the interaction with heat. So they highlight who's most at risk, and we know these are older people, pregnant women, young children, people with chronic disease. But we need to also remember that Aboriginal people are often overrepresented in these at-risk groups, particularly in remote communities where environmental infrastructure is so poor. So there's an urgent need to develop and disseminate evidence-based advice to such people, at-risk groups. And hence we have done this Whakathuni project. Whakathuni is in each Garama country, about 32 kilometres from Tom Price. You can see it's about 200 kilometers from the hottest place in Australia, Marble Bar, and this map is just showing that there's expected to be many, many more days over 45 degrees in those areas. It's current population of the small community. It's a homelands community. Is about 130 people that come and go quite a lot. There's lots of service providers with fragmented services, as one knows. And I think importantly for us here is that the infrastructure is in need of repair. The water quality, the shade, the quality of the houses, the power supply, all that stuff. So hence we put in a grant which was called the Whakathuni Heatwaves, and this is our project, our CI team, and we also have 3 people on the ground doing sort of more people on the ground there. The leadership really comes from Ros Walker and Auntie Joyce Drummond. Auntie Joyce lives there, and Ros and her have a relationship going back 2 decades, and she invited Ros, says, please, we need some work here, please come and do something. So we decided this was it, and so on invitation we've been working there for a while now. So the project aim is to co-design and implement protective adaptive strategies with the Whakathuni community to address the impacts of heat extremes. It's co-designed around community activities, really wanting to reduce those impacts, to learn about old ways of keeping cool on country, responding to the community needs and strengthening their capacity and resilience. And it's a 1-year project. There's not a lot you can do, and certainly not research. We're not going to show effects and those kind of things. So it's very much an action research. So our framework is an Aboriginal participatory action research, where we work in partnership with the community. We privilege Aboriginal knowledges, stories, and cultural practices. There's a commitment to work with the community priorities, to work at local level, and to work at a pace that is appropriate. You can't just go there and do, it doesn't work. So, and of course, strengthening understanding the impacts of heat was really very important, and getting much more capacity around that issue. So the focus was very much on actions, and we had 5 community-based activities that we did. Initially, we really just tried to get a profile in the community, overcome distrust and so on. I got an office in Tom Price, an informal reference group developed over time. We had discussions with service providers just to get their perspectives, got T-shirts printed and a newsletter, regular newsletter, and also had a lot of informal yarns, discussions with community. And we also had some engagement early on with the WA Environmental Health workshop. So activity 1 was a heat-related workshops that we held. Georgia Chasling, the same one who wrote that position description earlier on, she's on our team, and she came up to Tom Price. They ran workshops with service providers about the mitigating effects of heat, and lots of ideas of how they could use this information in the way they provide services. And there were also lots of informal yarns in the community setting. There were lots of ideas from the community, their perspective. There was a lot of frustration about the housing and the Department of Communities not responding to their demands and complaints. Complaints about greenery, the water quality is major, and I'll talk about that a little bit more. Complaints about mining, air conditioning wasn't functional, and intermittent power supply. So there you go, there's no power supply for 2 days and you've got 50-degree heat, those kind of things. So there was a lot of discussion about what they could do, room fans, and the idea of fans with misters. We actually then bought some and distributed them at various times. They helped us co-design some messaging around this. With the service provider, they started adjusting the work times to be in the cooler parts of the day. They changed the fabric that they were wearing to be more breathable. They provided refrigerated drinking water. Hey, this is not rocket science, you know. And some of the community members built a bough shed, which is a traditional shading that was used in the communal space. And also we started considering ways to adapt cultural activities. And for example, there was a big funeral related to people that were quite prominent on our project. And we developed a little guideline about heat. As it happened, it was a cool day, but we developed it. So those kind of things. So the next thing was citizen science. We had people collect some temperature and humidity measurements. They had some data collection sheets, and we also then interviewed them about how they could think we could beat the heat. We also created a Beat the Heat video, which that link is there, and we explained thermoregulation for the community about the effect on the body, how to prepare, how to help others, how to recover, all those kind of things. And and so we disseminated that quite widely, and it's available online, as you know. We also had a water sample collection. There was a lot of Aboriginal, there was a lot of anxiety about the quality of the water. There were complaints that the mining was taking too much water, and there was a lot of contamination. They're blocking traditional watering holes, so there's a lot of that there. The water not being palatable, they couldn't drink it, so they get dehydrated. They get these big plastic bottles, and then suddenly there's a plastic problem. And the corrosive effect of that water on the appliances and on the hair and on the skin. So all the air conditioning units are gunged up with this, et cetera, et cetera. So water is a big issue, and they've been part of a Homelands water hub for a long time, led by Auntie and Roz. So the Wakathuni community members, some of them assisted with water sample collection that you see on the right there to provide evidence to Watercorps that things are not okay. They do intermittent testing, but it's only for bugs. It's not for all those other things. And we've got a Murdoch student who monitored the water quality at various times of the year. This is some of his results. He found hardness. He found the turbidity level was high. But there were a whole bunch of things also he didn't do. So we're kind of trying to do more testing and so on. So the last activity was actually a water roundtable held at Murdoch University in July last year, with broad representation from various communities, service providers, government representatives, including Watercorps and ourselves, and we discussed the water issues, the facilitators and barriers, even from within government, and there was a commitment to supporting an NHMRC partnership grant to address this issue, and 9 of the communities are partnering with us, and it's going in at the end of this month, actually. We've got ongoing engagement with the community, and we have plans for further grants at the Shire and regional level. So then I'm busy working on something looking at disaster and heat management at the regional, at the Shire level, and so on. So we're busy doing that. So I suppose just bringing it more to this audience now. This was very much public health interventions and efforts, and what messages are there for the clinical settings? To what extent do hospital clinicians incorporate heat considerations into their discharge planning? Do clinicians talk to their patients about the effects of heat on health and provide resources? And do clinicians ask about home environment and the extent to which these facilities exist that might mitigate heat, particularly for Aboriginal people? And what workforce training is in place to prepare the system for this? Those are rhetorical questions you can discuss if you want. Sorry. So just bringing it all together, you can see this pyramid is true for everything I've spoken about today, for the general high mortality that comes from poor water and power and housing, to stroke and ACS, to RHD. It's that band that sits there of social determinants that is not only driving the problem, but it's also the place to which people are being discharged. So just to be mindful of that, and that's the end for me.
Thank you so much, Judith. Really a tour de force through a number of very important aspects. We talked about rheumatic heart disease, closing the gap. Oh yes, we need to use the microphone. Not that it's connected for those online. Hopefully you can hear us well. Lots of important aspects to discuss. I'll open the talk for discussions and questions.
I don't think I'm going to take something from Leon, yeah?
Oh, Judy. You mentioned the early period there was a reduction in rates in Aboriginal.
ACS, yeah.
And you also mentioned the problem with indigeneity in the record system. Was that Did that correlate with an increase in the denominator? Is that we're seeing that reduction in the rates just because the denominator increased?
We always looked at trends within a denominator system because we couldn't mix them because of that problem. So that's what our whole design was driven by this silly thing that we can't have consistent denominator.
And how did the denominators from the health record system compare to the ABS? Was the health record system markedly different from the ABS?
No, look here. The ABS was only population estimates, so we didn't. I think what you're saying is maybe we're starting to see greater indigeneity in the numerator, and that might explain. Is that what you're saying?
Yeah.
Because of that, there is a possibility that there is a problem of these two systems that are both increasing. We tried very much to look at any. We didn't just take the Indigenous identification at that time. We looked before and after, so it was quite comprehensive. Do you know what I'm saying? So it wasn't,
What's sort of the magnitude of that increase in indigeneity? Is it like twofold over that period of time?
You mean in the
Number
ABS?
of people, in the number of people who have been identifying as Indigenous?
In the census?
Over the 20-year period.
I don't think it's what did you say? What number?
Twofold? Two?
No, it isn't that much. I've actually got it on some slides. The number, it's about 10% per census it goes up. I don't think it's.
And there were 4 censuses there, 5 census.
Yeah, but we only so that they would use the information for 10%. A series. They would use it for the latest census,
5
and
census would be about 70-80%. 1.1 times 1.1 times 1.
Yeah, compounded. Yeah, I mean it's a complex thing. So we try to do the best we could with the information we have because we've got two things. We've got identification by going to hospital and saying you're Indigenous, and there we've got some strength because we're using. I didn't go into how we got that, but we used an algorithm used by WA Health where they go to all lots and lots of sources and they give an identification. So
they link the data.
The data to get that. So that is kind of okay, but it's not perfect because I think there's still the younger cases will be different, and then this denominator problem, and we stuck with it. It's really a big challenge. I've never done trends before because of this issue, and we just had to do it. I've been thinking about doing this. For every fellowship I ever applied for, there was this thing, and at last we got to it. But we really had to very carefully design it, and it's not perfect. I think there could still be some error, definitely. Sorry.
Any other questions? I'll do one, and then Laurie. In context of the rheumatic heart disease topic you mentioned, you pointed out that living in the metropolitan area appeared to increase the risk, which seems a bit counterintuitive. Usually it's the other way around for most risk factors or so. Yeah. Any ideas why that may be the case?
Yes, of course, when we first saw this, and it's coming up all the time. It came up in Northern Territory in a previous analysis, in our combined analysis, and this is all across Australia. And I think it's because, in the rural areas, people are more switched on to identifying it, and they're not perfect, but they're more switched on, and they're catching kids earlier, or people, and so they're putting them on prophylaxis potentially, and so on and so forth. But also the infrastructure is more geared toward it as well, And so I think, and the other thing is, within the metro area, it's not always completely dominated by Aboriginal people to the same extent. So that includes, Queensland and New South Wales, where they have a lot of Pacific Islanders and Maori coming from New Zealand that are in that group, and so it's and those might be settled in and also people from immigrants from low income countries. So they are often diagnosed late in the city because that's where they're living, and so on and so forth. So they are that group that's elevating, and they're often on the severe end. So it's quite a complex thing, but we were all, we've had to think about this quite carefully.
Better get out of here then.
Thanks very much, Judith. That's a wonderful coverage. As you say, a very complex area. If you drill it down a bit, were the populations you were studying alcohol drinking, or were they?
We do have that as we always look at it, and we have models, we often put that into, but this was more trends as a population as a whole. So we used aggregated information here, but when we look at risk factor information. It's at the individual level, and we do put alcohol into those. And yes, there is a relationship. Does make it work, but alcohol is not the dominant one. I think for the young people, and wherever you are, it's probably drug and alcohol is a big, and probably obesity driving that everyone's doing badly. It's not Aboriginal people particularly. And we also, into our models, we put diabetes and stuff like that. We didn't put it in here because that wasn't the aim. But yeah.
Coming to heat now, I mean, heat is a major factor restricting physical activity. I mean, it is even down here, but at least we've got air-conditioned buildings. And that must be I assume it's a major contributor to the obesity that you have in the remote communities and their incidence, therefore, of diabetes, for example. How do you see any way of getting around that in a remote community?
Look, I think there are complex risk factors. I think heat is only one, and heat is exacerbating, I think, the primary drivers. I think the social determinants are a major thing. Are you agreeing, Leon?
Physical inactivity is very commonplace in remote communities, which seems counterintuitive, but it's because a lot of people don't have meaningful work. So because you do a lot of incidental physical activity when you go to the workplace and so on, and there's a poverty of work available, so people don't get used to doing things.
But yeah. But I think the heat is an exacerbating. I think it's those other determinants that are major. I think what we're saying here is heat, and they've also experienced heat for millennia. It's been hot up there for a long, so they know about staying cool. But some people have lost contact with some of those means, and then the water holes are drying up because of mining, and it's all very complex. So I think you really do have to look at those social determinants. Yes, alcohol is there, but even that has the determinants in that. Do you know what I'm saying? It's yeah. So so one just has to go there, I suppose, work with the community, because there's a lot of strength there. And try and work with and build and be positive and be strengths-based, because otherwise we can all go, everybody can just go in a heap, and we shouldn't, and the population doesn't want it. So yeah.
Just coming back to the closing the gap
Yes.
theme you covered, it seems to me we unfortunately haven't been able to really make much of a difference so far. And what's the reason? What have we missed? What else can we do? I think there was a lot of effort, and perhaps the fact that just prior to that coming into place, there was a bit of a reduction to be seen. Maybe that was, preempting that. But how can we be more successful?
Look, I think a lot of the closing, again, it's that social determinants is really driving it. And in the end, if you tinker at the top, you can change things a bit. And I think stroke did, if you think of the actual gap, it closed. It has continued. There's a good closing of the gap. ACS, not so much. But I think we can't give up. There's, it's really about, on the clinical side, the upper part of the pyramid for clinicians to be informed about what's going on, give services where people feel safe, all those kind of things that I think you've all heard about, but also make sure that the discharge is a proper discharge. It might be that you recommend, cold water 3 times a day. You actually write it down, or have, get cold, whatever the case, or just drink water, or whatever the case may be. Just those kind of things to actually ingrain it all. But I think closing the gap is a complex thing, and obviously there was the voice that was people were devastated by the no vote, and that's why that's in that hierarchy, that recognition and rights. That's what I was referring to, kind of more engagement. Yeah.
But it's not entirely negative either. I mean, the mortality shown benefits.
Cardiovascular mortality has definitely gone down.
And there are things that are actually, the gap's narrowing a bit. So it's not all the outcomes are the same.
Exactly, and all age groups is not the same, and sex and males and females are not the same. I think that's the complexity of it. So I think young people, you can see here, nobody's doing well with stroke. It's just bad news for stroke, So I think one has to be also cautious. some people don't like always epidemiologists who do comparisons. They say it's not a strengths-based approach by comparing Aboriginal to non-Aboriginal. Unfortunately, we've kind of we've built this into that particular analysis because it's closing the gap. The word gap is already a negative word, and so on and so forth. But you can see how important it is to know what's happening in the rest of the population, like with a stroke. Otherwise, it's, my God, what happened there? Well, it's happening for everybody. And obviously those men, those older men really benefited from that. And there could be other artifacts in the data, we don't know. But it was consistent almost across the board, that pre-period. And I spoke to Graham Hankey because he's on that paper, and Tim Kleinig from South Australia. And we kind of workshopped, what is this? What happened? And suddenly it was, you treat AF with anticoagulants, and much more aggressive hypertensive treatment. It was all happening in the first decade or half decade of the century. So
you didn't have to check
no, exactly. All that was happening then. Yeah, and
you could just prescribe.
That's right. Maybe just the other thing I want to say is we've got a publication that should be coming in, I think it's happening at MJA, where we've done a systematic review looking at the age at AF and recommending a change to the guidelines so that for Aboriginal people they start screening younger. So that's just by the way, yeah.
If there's no other questions, please join me in thanking Judith for a fantastic talk and giving us, an update on the situation in the Indigenous people. So thank you so much. Thank you.